Say, guys.
Yeah, I think we should. I think it's probably wise to start. So
Yeah, that's on already.
it's on already. Okay,
Brian, do
very
you
good.
want to do an introduction? Brian?
Well, yeah, I'd be happy to. Look, you know, there isn't anybody on the internet yet, but there most likely will be. You know, what we've got here is a team. You know, and Melvin has got some of his team members here, and Emily Provost from the engineering college is well known to us and is a fantastic collaborator for Melvin and the team, especially bringing out capabilities and, you know, a lot of things, you know, engineering and machine learning and engineering inspired behavioral science, and, you know, tailored to your application. We brought Melvin here from Johns Hopkins University after a career that spanned up in Canada, and he's from Iceland originally. And he's literally a man of the world. He came here to lead our efforts in bipolar disease research. He's currently Associate Director of the Depression Center. He's a chaired professor in the Department of Psychiatry. He's a delightful person and a good friend, and we're very excited to see about what you're up to. He's been recently involved using cell phones and tracking, you know, in bipolar disease, and he'll tell you about that. And you know, cell phones and tracking people's behaviors, whether they be sleep behaviors or when they're up or where they're at or all these kinds of things, could be a marvelous, you know, additional information to help us understand bipolar disease and its treatment. And he's been a great thought leader in that. And so we're just delighted to have him.
Thank you. Thank you very much, Brian. So I was told that people kind of stand off to the left here, and so I will do that with the clicker. And I'm going to take as little time as I possibly can. Just want to introduce the project because I have some colleagues here, John Gideon, who's going to talk on his work, and Sohail Khorram, who's going to talk on his work. And Emily Moore Provost is the faculty in the Computer Science and Engineering in the College of Engineering that is supervising this work.
Okay.
The clicker isn't clicking. Just yeah. Okay, good. I just want to do one plug. So we'll just work on here. One plug for the Prechter Fund. So we have a lady, Mimi Baird, who's coming to do the Prechter lecture on October 19th. This is a lady who found her father's memoirs in a big box. Father was his name was Perry Baird. He actually came through the University of Michigan in the 40s, and so she published this book, He Wanted the Moon. It is a discussion on bipolar disorder and his experiences with the healthcare system in the 1940s. Her father died. It's fascinating. And so she's coming to talk on the 19th, and it is our understanding and knowledge that it's going to be made into a movie with this fellow Brad Pitt.
Well, he's got a little extra time on this.
Yes, right. And so the outline, what I'm not going to
keep up with you, Melvin. It's
yeah,
hard.
no,
It's
no.
impossible.
So I'm just really going to be this slide. I should have edited it out, but really just going to talk about bipolar disorder a little bit with the impulsivity and the reactivity. I'm going to talk about it from an energy perspective, and then these guys are going to talk about PRIORI. But firstly, in terms of bipolar disorder, so many of you know me from my research in bipolar. I've thought a lot about how to start to boil down the phenotype. And so a common thread here is energy. So thinking through the manic state, bipolar disorder has mania and depressions. And think of the manic state as a high energy state, and think of the depression as a low energy state. And so visualizing that, and we sort of see it in the classical paradigm there of the sine wave, as such. Okay, so I did put this in. So I'm just going to talk about some reactivity and impulsivity in bipolar disorder, and using the example from response inhibition in impulsivity and suicidality. So the average person with bipolar disorder, even when they're well, they are not like the person on the street. In other words, they have a tendency to be, does it work? Problem is I have this genetic disorder. Oh, it's yellow. It's green, so I can see it. The red one I cannot see. And so we are studying the response inhibition with Patty Delden in the labs there, and we're using the P300 deflection at 300 milliseconds as a measure of impulsivity. The way that they do this...
Just explain what that P300 is.
Yes, I can do that. So P300, and so when you put an EEG on someone's head, at P300, 300 milliseconds after a stimulus or after a request to do something, can measure that, and it's the deflection, electrophysiological deflection on the brain at the 300 millisecond time point. And so it is thought to be related to a measure of impulsivity at P300, and we can measure the go, no-go stimulus there at that state. And so this is what they're to do. They're asked to hit the button when you see the go stimulus, for example, at the M here, and you don't hit the button when you see the no-go stimulus at the W. You can vary it up, and you can look at when the go, no-go stimulus is either a neutral face or a happy face. So the bipolar individuals, when they are seeing a no-go stimulus, so that neutral face is the go, so every time you flash a go, you see, you hit the button. When you see the no-go stimulus, the happy face, you don't hit the button. And so what you see here is that there is a significant deflection at the happy inhibition to stimulus, the no-go, when it's a happy face, indicating that these individuals are relatively reactive even when they are well. So there's this dynamic state in these individuals that reflects an instability of mood and an instability of behavior, instability over time. And the reason I wanted to talk about that was that it gives an excellent introduction into the ongoing variability over time of these individuals as they are being monitored. So what you're looking at here is time periods, 1 week time period here. Each week, this is over a course of a year, an individual is filling out symptom severity measures. So here we have the depression, the mania score in the red, the Young Mania Standardized Rating Scale. The Hamilton Depression Score here in the blue. And so you can see an individual, their moods are going up and down from both the depression perspective, and they're varying here in the context of the manic symptoms. And so someone who is less than 5, sorry? Yeah, so there's so individuals vary in their amplitude and their period of their variation, and so the mathematicians are playing with this to look for patterns. But what you can see is that things are going up and down all the time. And so in trying to make sense of this in the context of this instability of mood and the instability of both the moods going up and down and their behaviors, I just printed it out and took it home to my wife, who is a theoretical physicist and an oncologist. And so in her capacity of physics, she said, well, what you've got going on here are a bunch of dynamic states. So what's going on in these individuals with bipolar disorder is that their moods are going up and down all the time. And so we then questioned whether we could use speech for mood monitoring. So the hypothesis was that speech acoustics would serve as a proxy measure for internal emotional, mood, and affective states. Very simple, straightforward hypothesis. Speech, of course, is modulated by the internal state of the individual. Psychiatrists, clinicians, we ask about, talk to our patients, we listen to how they talk, and the way they talk, what they say, how they say it is a very integral part of our assessment. So when we get histories from the families, typically they will say, somebody is just admitted to hospital for a manic episode, and they will say, I could hear it in their speech. There was something different about them, a week ago. They were just different. You could hear it. And so then we asked the question, well, if a human being can start doing that, can we can we devise an experiment to see whether or not we can identify features of speech over the course of time in individuals with bipolar disorder and use that data from acoustics to identify moods and predict moods. So data that we have 50 individuals, 10 healthy controls. For the bipolar individuals, we conditioned on having individuals with rapid cycling. We asked that they have the device and talk for at least 60 minutes per week. And we have weekly assessments with a Hamilton Depression Rating Scale, a clinician-driven rating scale, and the Young Mania Rating Scale.
Wow.
So the assessments of it is that we have weekly assessments, as you saw on that curve. People are going up and down all the time. Individuals with bipolar disorder, they're unstable even when they're relatively well, as you saw with the ERP measure. And we're getting data from them for 1 year. So what we did, so we got an R34.
How long does it take to get the ham D in the wire?
The interview goes for about 20 minutes to 30 minutes, depending on the nature of the symptoms. So they talk for about 30 minutes on the phone with the therapist once a week.
I see. And do you use that as part of the 60?
We use that as no, that's not part of the 60 minutes. The amount of talk that we got from them was not a problem. That was plenty. And so some people would. So what I was about to say. So what we did was we buy them a mobile device, an S5 at the time. We pay their data plan, unlimited talk, unlimited use of the phone, and we pay them to participate in the study. And so there's a modest incentive, for that. And so there's not much to not like about the deal. So the project was that every conversation that the individual has is recorded on the device. The incoming conversation, Brian calls me, my speech is recorded, Brian's speech is not. We have to adhere to the law, and you can't record incoming speech without the person's permission.
In your previous graph about the depression score and the mania score, why aren't they completely negatively correlated, or why doesn't one go up and the other goes down?
Thank you very much. Excellent point. So the typical way that we think about bipolar disorder is that you're either manic or depressed, right? And so that's what the average person thinks. But in fact, that's not really the case. So you can have states where you have energized elevated state of energy and a deflated dysphoric mood. So things are going up and down, irrespective of each other, just regardless of what the depression state is. The manic state can go up. So it's almost as if they're behaving independently, isn't it? Yeah. Sir.
Fascinating.
If somebody's in a manic state, they're more likely to talk
Correct.
quickly.
Yeah.
But if somebody's in a depressed state, they're less likely to interact with the world.
Right.
They're real likely to close in. How do you guys account for that enrichment?
So that's not entirely true, because people, when they're depressed in here, so that they will call up and they will complain, or they'll talk to somebody, and I'm really feeling depressed and sad. And so that's the sort of classical kind of a way of thinking about it. And for some people it's the case, but not everyone is the case like that. And so you have someone, and so the other thing is that, but I mean, there's so much data and so many opportunities to look at all these different features that is to ask particular questions like that. Now, so speech, analysis and depression is nothing new. So this has been done before, and these are the papers that are there, and you can go and look at them and read them and find that, yes, they found features of depression in the acoustics. But what they haven't done is they haven't generated a data set that is passive. So most of the data, or the data out there to date, is generated in the context of like our assessment calls. It's a kind of a contrived conversation, or you record something and they use that data to analyze and associate that with moods. You can recognize the actor there. Does anybody know the movie?
Oh, yeah.
What is it?
Sabrina. That is a great movie if you hadn't seen it. Maybe made it a couple times.
Thanks for that. No, so here's really the essence of what PRIORI is doing. And so what we're looking for, this is a very simplified kind of a drawing. So we're looking to see if we can identify features of states and state changes that would generate an early warning sign. We're not at this stage in the experiment yet, but can that early warning sign identify a need to intervene? And so the point being, if you can intervene timely, one could mitigate, if you will, the manic episode, or mitigate the depressed episode. So this is the reason why we're doing this, is to prevent So before I end, I just want to describe for you the experiment that we're doing. As I said, individuals get the phone, they use the phone, the application records the outgoing speech of the individual, sent to the computer science folks for feature extraction. The HAMD and the Young Mania are there to identify the mood states, mood state estimation. And then the support vector machine system looks at the decision-making process and determines whether they're in a manic, euthymic, or depressed state. And so that is about as far as I can take it. And so I'm going to turn it over to John Gideon from Computer Science and Engineering to talk about his work on the project.
Thanks, Melvin. Should I wait?
I'm just going to try to fix this.
Okay.
You can use the keyboard.
He's wearing
No, he's trying to fix the clicker, I think, right?
Yeah. In the meantime. There you
Okay.
go.
Wonderful. All right. Also importantly for this, all the audio that we record on their phone is encrypted immediately before it's uploaded. And then when it's in the feature extraction process, that's all done in an automated way by a computer. Okay, so I'm going to be mainly going into a bit more technical detail of one of the publications that is one of our more recent submissions back in March. We looked at being able to predict mood from speech, but in particular looking at the difficulties that come up with different variations in acoustic quality. Because like Melvin mentioned, the recordings that we have are not in laboratory settings. They're just from everyday use of the phone call. So, as Melvin mentioned, speech patterns have been shown to reflect mood in the clinic, but often in these previous experiments, we found that they're in controlled environments, like a laboratory setting, and they often only have one single type of recording device, usually like a laboratory or a very professional-looking microphone, which does not look at all like somebody's cell phone microphone. In real-world recordings, there are big variations in background noise, and there's also variations in microphone quality. So the idea is speech recorded in the real world has large variations in quality, but this would make distributed mobile health systems, like ones using cell phones, infeasible without controlling for these differences. So to go into a bit more detail about the current makeup of the database, we have about 51 subjects enrolled that have bipolar disorder. They're enrolled for between 6 and 12 months and given one of the phones. At this point, we have about 3,600 hours of phone calls across 45,000 calls. Of those 45,000 calls, a subset, 1,300 of them are those weekly clinical phone-based assessments. Now, on average, those are about 15 minutes each. These phone calls are a structured clinical interview, so they'll be asked questions like, have they had feelings of guilt over the past week, insomnia, anxiety, weight loss? And from these, we can form the mania and depression rating scales of the YMARS and the HAMD that Melvin was showing earlier. Of these assessments, 23 of them were transcribed for validating algorithms later on, and I'll bring those up in a second. But in particular, for this analysis I'm going into, we only use the assessment audio. So the idea is trying to take the phone call where they're calling up the clinician and predicting the mood of that rating that comes out of that assessment. We're not using the rest of the personal calls in this analysis. Later on, so Hal will be giving a presentation where we do start beginning to use some of these personal calls.
It's just more just baseline technical. 3,600 hours and 45,000 calls. How much memory is that? I think it's sort of.
I don't think it's a terabyte. It's probably like 50 or 100 gigabytes. It's in non-compressed wave format, so it adds up. But I think somebody asked earlier, on average, how much people call. I think it's about, we saw that people are calling about 15 minutes a day on average. So that's the idea of the order of magnitude a day that we have. So about a total of 2 or 3 hours a week.
So the people who do the interview, they will base that on this, not on reading the transcript.
Yeah, the interview is just a clinical interaction. How are you feeling today? It's, oh, I'm feeling really great, or I'm feeling really crappy. Oh, what happened? Oh, my dog died. So it's an interaction like that. They have a guided interview that they're following, and so it's asking about energy, and so they will say, well, so how's your energy been over the past week? And then we'll talk about it. So it's some of the conversations when they're negative, they say, how's your energy level? Oh, it's fine, no problems. And then they'll ask a question, have you been sad or at all for the past week? And they'll say no. So we coach them to interact and say, so well, what's that sadness about? So we get some spontaneous speech.
So the interview is not fully dissociated from the acoustics.
Correct.
If they are not trained to ignore that, they may subconsciously incorporate that in the diagnosis. Fair enough.
Fair enough, yeah. So the clinician listens to them, and that's part of the clinical assessment. It's a global clinical assessment. So if somebody sounds really sad, then that will influence how you rate that.
Yeah, we've done a lot of thought into trying to figure out this relation between like the interview and the ultimate rating and the acoustics of it, and try to control for that and how we form the audio.
I mean, what we're trying to do is get a biomarker. I was trying to establish a biomarker essentially for depression. I mean, there are no biomarkers, and so there's no gold standard. There's no ground truth here. So that's the challenge.
The idea is by working on these assessment calls first, we know that given people's personal calls, just everyday random phone calls, might not have as clear a manifestation of mood. So this is a good first step to find those biomarkers before moving on to personal calls.
But you could validate that as well by, since the interviews have been transcribed, you could do a double-blind study to do equivalent ratings just from the transcript and see if it's a bigger variation than double-blind variation based on the conversations.
And the other thing we're trying to do is to get a team of students to listen to some of the audio and sort of rate that. Can you rate the affect or the moods or the depression level, or just based on listening to that? But that is a lot of work, and they have to have really good training and listening to. Have a standardized way of rating it. I mean, that's a non-trivial issue.
Yeah, we're really interested in trying to get some sort of human baseline for this, just to see where we can go from.
You said you have 51 subjects that are diagnosed with bipolar. How many subjects do you have that are controlled?
10, I believe, that are controls, although we're not using those in this study.
Calls from the 10 controls.
In this study, we're just using individuals that have bipolar. Okay. This gives an overall distribution of the Y-Mars mania and Hamby depression scores. So as you can see, there are some people that have both in certain situations. But for this experiment, we decided to break it down into discrete classes to help aid the techniques later on. Talking with the clinicians, we came up with less than 6 on both scales, less than or equal to 6 on both scales is euthymic, or the healthy state. Greater than or equal to 10 on the Y-Mars scale is considered to be manic, and then greater than or equal to 10 on the Hamby scale is considered to be depressed. And the idea behind this is, as this first experiment, trying to come up with discrete classes to see if we're able to differentiate between this presence of mania versus euthymic, or depressed versus euthymic. So for this study, the participants had 2 different types of phones that they used, the Samsung Galaxy S3 and S5. And initially through the study, this was not something that we particularly looked into. But we upgraded participants into the S5 later on as new phones came out. So we had about 18 participants that had enough data on the S3 and 17 participants that had enough data on the S5 at the time of the study to be included in the analysis. There's a bit more for the S3 in terms of assessments because this was earlier, so more participants were farther through the study. So there was more data. But as we found out when we looked further into it, the audio quality between the 2 different devices was actually starkly different. Ways of looking at comparisons between this quantitatively is there's over 100 times as much clipping in the S3 versus the S5. Clipping is, you can see it here where it's being cut off at the top. It's called clipping because you can imagine like scissors going through and cutting off the peaks of the signal. And essentially this is where the signal should have been more recognizable, but the microphone sensitivity was too low or tuned to too high a sensitivity to pick those up. In addition, the S3 was 6 times as loud as the S5, likely due to that microphone sensitivity issue. Finally, there was a 3.9 decibel drop in estimated signal-to-noise ratio going from the S5 to the S3, which means that there's much more noise in the S3 versus the S5. So looking at all these issues, we came up with a pre-processing pipeline to address each one individually. First of all, we looked into and implemented a technique called R-bar, which helps to declip the signal. It essentially looks at what the signal could have been and extrapolates it. We also did audio normalization to deal with the loudness issue, and noise robust segmentation to, while dividing the signal into the different audio sections, controlling for the noise differences between types of phones. So first, looking into the declipping method. I originally found C-bar, which was a method that tries to extrapolate clipped regions of speech. So here you can see a signal that's clipped off here and here. The idea behind C-bar is it tries to minimize pointiness, which is acceleration, while also making sure that the signal extrapolates at least beyond this amount. Because the one thing that we do know from points here is that they should be at least higher than that area where they're clipped off. So that's what C-bar does. It extrapolates. It's not going to get it exactly back where it could be, because ultimately it's not going to be able to, because that data is lost. But this gives an idea of what the signal could have looked like, and it's a better representation than just leaving these flat. However, C-bar actually is very slow to run on speech, and because we have huge amounts of phone calls, it was impractical to run on. So the people that made C-bar also made R-bar, which is a fast approximation to C-bar, which we ended up using in our pre-processing pipeline. And to give an idea of what a signal looks like once passed through this, you can see the before and after of a signal going through this declipping method. While it's not a perfect reconstruction, it is better to pass this into our later algorithms for feature extraction than the clipped speech. Next, we did the normalization, followed by noise robust segmentation. So the idea behind this paper by Sajidi et al. Was that we use 5 different measures of speech activity. So what we have is we have a long conversation, lots of which has silence in between when the other person's talking or when both of them are silent, or just some background noises. So what this does is it filters out all that and just produces segments of speech, which we want to look into. The 5 different sources that this paper considered was harmonicity, clarity, prediction gain, periodicity, and perceptual spectral flux. These were combined together using principal component analysis to just make one signal for the likelihood of speech being present in a region. We then smoothed it with a Hanning window and normalized by the 5th percentile and standard deviation, which allowed for the signal to be comparable across different phone calls. Once we reached this point, we used those 23 different transcripts I had previously mentioned to come up with the threshold and the amount of minimum silence that we should use in order to best optimize the creation of segments. Because in the transcripts, we already had those segments well defined. Once we applied those, we only included segments that were longer than 2 seconds, and sub-segmented within those to find 2-second segments with 1-second overlap. And that's for the feature extraction, which I'll go into in a bit, but this gives an idea of what's actually going on. So the feature extraction will be performed on these 2-second subsegments. Next along the pipeline, we did feature extraction, which is feature extraction, call level statistics, and then normalization. So I believe you actually mentioned this earlier. Manic and depressive speech have rhythm-related symptoms. In particular, manic speech is more frequent, it's quicker, and it's louder. While depression has a slowing of speech, sometimes slurring of speech, and difficulty articulating. So in this paper, we explored mainly rhythm features because they are symptomatic across both types of moods. We used 2 constant 2-second subsegments. The idea behind this constant 2-second subsegment was to just control for the features in using a consistent size segment in which to extract them. Additionally, the paper that I previously referenced showed that 2-second subsegments are long enough to have enough rhythm to be able to form a good measurement of rhythm, but they're short enough that they don't have so much variation that a measurement of rhythm is difficult to attain. Over these 2-second subsegments, we extract the audio envelope. We extract 7 rhythm statistics over each of these audio envelopes, and then form together using 31 statistics over all of these statistics, a 217 call level feature. So this means that for each assessment call, there is one 217 dimensional representation of that call acoustically. Finally, we normalize either globally or by subject. Globally means that we would take all phone calls across all individuals and subtract their means and divide by their standard deviation. Subject normalization means that we would just do that on a subject-by-subject basis, which could potentially allow for subjects to be more comparable because it zeroes out all their means individually. And I show an analysis of doing both those different types. So finally, we have SVM classification, or support vector machine, which is a type of machine learning analysis. As I mentioned previously, we consider the binary cases of mania versus euthymic and euthymic versus depressed. We use participant-independent testing, which means that, say we have 15 subjects for the mania test. We leave one of them out, and we train a system using 14. We then test using the one that was left out to see how well it can predict that one that was left out. So it gives an idea of the generalizability of the system. Additionally, in order to be included in the study, we ensure that participants have at least 6 phone calls, of which at least 2 are euthymic and 2 are manic and or depressed. We use participant-independent validation to match the testing. And in validation, we determine which of these features are the best to use of those 217. We also experimented using a multitask support vector machine, which essentially what that does is it includes as a second task the phone device. So while learning, the process knows whether the audio clip came from an S3 or an S5, and it can take that into account when doing the learning procedure to potentially make calls from different devices not have as much weight as a call from the same device, for example. Finally, we use the performance measure of area under the receiving operating characteristic curve, shown here. Random classification will be 0.5, while perfect classification would be 1. The intuitive thought behind AUC is given 2 samples of, given 2 predictions, what is your likelihood of ranking them correctly? So if you were perfectly random, then it would be 50% every time. Well, if you had it perfect, it would be 1. So here are our results from this analysis. Number 1 at the top here, you can see our baseline, which was 0.57 AUC for mania and 0.64 for depression. Once we added in these different types of preprocessing methods, declipping, normalization by subject, and multitask learning, we saw a significant increase in the performance of mania AUC. And one possibility for this is when looking at the audio between the S5, within the S5, we found significantly more clipping in manic than depressed calls. And this is kind of intuitive because individuals may speak more loudly in a manic state than in a depressed state. So that's why it's potentially having the best benefits for classifying mania. However, we did also see that normalization by subject significantly improved both mania and depression. One possible reason for this is the subjects use the same phone the entire time that they're within the study. So when you're normalizing by subject, you're also implicitly normalizing by device. In conclusion, for this study, the results demonstrated our ability to counter variations in recording device quality, such as clipping, loudness, and noise, using these different methodologies. We found significantly better than baseline performance by using these methodologies, but we did find there wasn't an overall comprehensive solution. So we really need to look into the different types of methodologies that we can use in order to find the best method for certain types of tests. Hopefully in the future, we could use this as an ability to increase subject comparability when we're performing analysis on personal calls following the assessment calls. But that's all I have for my presentation. Are there any questions relative to this presentation before we move on? Sure.
So I think that one of the things I think we should do is there's time for one, maybe 2 questions. So one quick one.
Do you want to consider doing subject-specific preprocessing?
You mean trying to learn different...
different person might have different contours or clipping or other features.
Yeah, that's something that we've considered doing, also potentially device-specific preprocessing.
I'm really interested.
So that's great.
Yeah, so Hal is particularly interested in building subject-specific models. But you're talking like doing subject-specific preprocessing, right?
in other domains, you can normalize or batch correction at different stages. And you made a decision to do subject-specific normalization after feature has been extracted. So that seems to be a decision that can be bracketed by other decisions.
Yeah.
And it's exactly so. Why we're collecting the raw data, raw audio data here, and so there are there's bounding with opportunities to really go in and do kind of a whole series of different types of experiments. I'm going to call Sohail to come up now and talk about his project, and so then
That's really good.
have a general discussion after he's finished. So maybe we get your
So the big lesson learned is the data science conundrum that 85% of the energy went into the data scrubbing and the pre-processing of the data so you could analyze it. It's a huge cost center for the whole field right now, and nobody seems to want to fund that.
So what we're doing now is that we've got a contract with Amazon Cloud, and so we're using mCloud, and so now our device is such that it works in Mexico, Lebanon, Norway,
that's fine.
and around the U.S. So people can be using it, and it bumps the data into the Amazon Cloud, and it can be analyzed there. And so Sohail is one of the postdocs in the group, and has been working on this, and just presented his data at InterSpeech 2 weeks ago in San Francisco. So we're very proud of his accomplishments in such a short period of time. So Sohail, please.
Yeah. Hello, I'm Sohail Khorram, and I'm a postdoc working under supervision of Dr. McInnis and Dr. Provost. I'm also working in the PRIORI project, and in this presentation, I'm going to present my work published in the recent InterSpeech conference. And I'm really happy that you asked that question, because my work is completely in the same direction of your question. My work is about applying subject-specific information into previous population general models that John explained. Most mood prediction systems usually assume that the symptomology of patients can be modeled using a model for all subjects. They train a population general model for all subjects. But this population general model cannot capture subject-specific information. And we know that subjects are unique, and there are a lot of subject-specific information that we can use in our modeling approaches. So the main idea of this work is to incorporate subject-specific information into previous population general models to improve the performance of previous systems. We also use PRIORI database. I don't explain PRIORI database. John explained that. In this work, our focus is just on detecting depression versus euthymic. Depression, this is the distribution of our database, as John mentioned. And at the time of preparing the paper, the database contained I think around 40,000 calls, and among these calls we defined 3 classes: depressed, euthymic, and excluded. Depressed is defined as a score of 10 or higher for HAM-D and lower than 10 for YMRS. Euthymic is defined as a score of 6 or lower for both HAM-D and YMRS. And at the time of preparing database, you can see the distribution of this database. The goal of paper is to detect these 2 regions. We want to train a classifier that could separate these 2 classes. Okay, for population general system, we used rhythm features, as just John mentioned. To capture subject-specific information, we used a feature set called iVector. I vector is a successful representation of speech variability. As you know, speech contains many sources of variability, such as age, gender, speaker ID, or emotion or mood. And it has been proved that I vector can capture speech variability. And so we can use that in mood detection. And we found I vector. We found that I vector can capture subject-specific information as well. In I vector, each utterance is represented by its Gaussian mixture model mean supervector. And the Gaussian mixture model, or GMM mean supervector of each utterance, is modeled using this equation. In this equation, M of U is the GMM mean supervector of utterance U. M is the GMM mean supervector of the global model or universal background model. T is total variable matrix, and W is I vector. I will explain these ones. But the point is that in this equation, you can see the difference between M of U and M, or the difference between mean supervector of this utterance and mean supervector of the universal model. This difference lies in the low dimensional space spanned by the columns of total variability matrix. It means that I vector, if we want to define I vector in simple words, we can say that I vector is a low dimensional representation of difference between model of this utterance and model of the global model. So it captures the speech variability in a low dimensional space. And when we say low dimensional space, we mean a 400 dimensional space, because speech contains a lot of variability. So one interesting point about I vector is that we could use personal calls to train our I vector extractor. Because for I vector, we have a lot of unsupervised algorithms to train this structure. So we can use personal calls, and we're lucky that we have a lot of personal calls to capture speech variability from that. This is the overall block diagram of our I vector extractor. I will explain that real briefly. We have personal calls and assessment calls. First, we extract frame level features. For frame level features, we use MFCC. MFCC is a well-known set of features for speech processing. To extract that first, speech is we applied 25 millisecond framing to speech. After that, for each frame, MFCC features were extracted. Cepstral mean variance normalization is applied to MFCC features. After that, delta and delta delta features were extracted, and finally, speaker or voice activity detector is applied over the extracted MFCC features. After extracting MFCC features for all personal calls and assessment calls, we train the total variability matrix and actually the I vector extractor over the personal calls, and finally. We extract I vectors for all assessment calls. Then we use assessment calls, and then we normalize assessment calls using WCCM technique, within class covariance normalization techniques. And finally, after that, we trained our classifier, I mean the SVM classifier, to detect depression versus eutymic. The whole point of this structure is to we can use personal calls to obtain our feature extraction method, useful feature extraction method. And after that, we used assessment calls to train our SVM structure. In this study, 4 different systems were trained. For reading features, a population general SVM, as John mentioned, were trained. For I vectors, a subject-specific SVM is trained. For And also, we used two fusion systems, feature fusion and decision fusion. For feature fusion, we first combine features together, and after that apply SVM. For decision fusion, we first apply SVMs, and after that combine the SVM scores using a linear equation that we can see here. In this equation, lambda is the base of population general system. And in decision fusion, we used three different decision fusion algorithms: constant, hard, soft. Constant lambda is fixed. It is equal to 0.5. It means that population general system and subject specific system have the same effect on the final system. For hard, we select one population general or subject specific system, the best one. And for soft fusion, we select a weight between 0 and 1 to combine population general and subject specific system. Here you can see how we divide our database into a test and train set for population general rhythm system. In this figure, each node represents a data sample. The shape of nodes represents subject ID. Red regions represent test samples, and blue regions represent trained samples. As you can see, for population general SVM, the data for one subject is left out, and the data for all other subjects is considered for train. And we test on the data that has been left out. For example, different iterations of population general system will be something like this. For subject-specific classifier, one data sample is left out and is left out for test, and all other data samples for that subject is considered for train, as you can see in this figure. And for feature fusion, we use all data samples. One data sample is left out for test, and all other data samples for this subject and all other subjects are considered for training our model. And to train our SVM, we have some parameters, cost and gamma of SVM, that should be defined through the cross-validation mechanism or technique. We use two different kernel types, linear and radial basis function. For feature selection, we use weighted information gain. I just named them. For class validation, and as the class validation measure unweighted accuracy, is used. Unweighted accuracy gives the same weight to different classes. For SVM score, the commonly used sign distance to hyperplane were used, and actually our database is too unbalanced to handle this problem. We use weighted information gain and UAR, and also weighted, and also the data samples are weighted to handle unbalanced problem. These are our results. As you can see, the first two rows represent our baseline rhythm and I-vector features, and all fusion systems, the results for our fusion systems are represented in red rows. Two measures, UAR and AUC, were used for the test results, to compare test results. UAR, or unweighted average recall, is unweighted accuracy, and AUC is area under the curve of ROC. As you can see, for population general system and subject specific system are quite similar to each other from the point of UAR. Population general is a little better. For AUC, subject specific is a little bit better, but the variance of them are quite different. the variance of I vector is much higher than the variance of rhythm. It means that rhythm can work more consistent for different subjects. And it is reasonable because for I vector we just use data for one subject. The database is smaller, so this high variance actually makes sense. Three fusion results. All fusion results are better than the baselines, but 3 of them are significantly better than the baseline rhythm features and rhythm system. One interesting point is that soft decision fusion works well, and it also provides really small variance. It means that it is consistent over different subjects, and it provides a stable system. This is the results for different subjects. Results of rhythm, population general system, I vector subject specific system, the soft decision fusion, and the weight that we use to combine these two systems, the number of euthymic, number of depressed, and number of personal calls. As you can see, for I vector, 4 numbers are lower than chance, but a lot of numbers are better than rhythm. So I vector is not really stable, but when we combine I vector to rhythm, we have really better accuracy. One interesting point is that decision fusion selects better system when the different systems are different from each other. For example, when I vector is much better than rhythm, it selects I vector. When rhythm is better than I vector, it selects rhythms. But in some cases, when I vector and rhythm are similar to each other, it actually combines both of them and outperform both of them. And for a conclusion, we showed that it is important to capture both subject-specific and population general information. We developed a soft decision fusion algorithm to combine these two systems, and to train I vector, we used personal cars. And also, these results show that we're able to have a population general system for initial users, and after that improve the performance of that system gradually by capturing more data for that patient. For feature fusion, one important problem of subject-specific system is that we don't have enough data. So if we use similar subjects in our classifiers, maybe we can outperform these results. And thank you for listening.
Great. Do you guys have any plans in the future to actually use some of the words and what they mean? Instead of just looking at patterns, actually look at what they say.
So that is a sensitive issue. So at first it took us about 2 years, 1.5 years or so, to get this through the IRB, and we got it through the IRB because we specifically are not planning to listen to the content and the lexical content of the conversations, and so if folks knew that we were going to be analyzing what they said, then there would be less enthusiasm, I think, in this. And that we can use the content of the assessment calls, for example, to do that. There are many different strategies and things we can do. For example, when somebody's in an episode, we can just, in going forward, could you call in and just, give us a piece of your mind, if you will, or there'll be some way of someone to call in and share with us what's going on or have a conversation, and particularly when they're in a manic state or depressed state.
Yeah, so use this as a way to get them to call to get that information.
Yeah, so what we want to do now, though, is we have the system downloadable from Google Play, and then the data can be bumped into the Amazon cloud. So we want to get as much data as we can. We do want to go forward getting clinical assessments in the current, so in a similar manner, and potentially with daily assessments of the individuals, after a 3-minute call. So the real question becomes, which calls should we analyze?
Yes.
Yeah.
And listening to the assessment calls is really fascinating, because you have a or a 15-minute call, where should you drop in on that call to assess the the features of it? And so it turns out some people, when we were listening to them, at the end of a sentence, their voice drops off in the context of a depressive episode, or in other people, you hear it in the beginning of the sentence, or going up like that. So the human brain has the capacity to integrate that data, and sort of you get to know how a person sounds in a particular mood state. And so the real challenge here is to determine from a computational manner what part of the sentence, what part of the speech you should actually go down on and analyze, correct?
Yeah, sure.
It's also important to look at like subject-specific differences too, because subject-specific, you have differences in the acoustics, but you also have differences in the way that people manifest their symptoms. So, as was mentioned earlier, some individuals might interact less with the world when they're depressed, but some might instead go on social media and post a lot on there, for example, as their way of expressing their symptomology.
In fact, so what we're doing also, so we got IRB permission to, to capture all the strokes on the phone. So every time you stroke the phone or do anything on the phone, we capture that, all the the gyrometer, the accelerometer, and a GPS coordinates, and the amount of data in and out, even the battery degradation rate, would be significant. So the whole concept of psychomotor activity is captured in the context of the device. The other thing that we're particularly excited about this for is that and why bipolar disorder is such I think it's the most fascinating illness in the history of humanity, essentially, because the variability of it is profound. So can we use the information gathered from bipolar disorder to identify features that would predict sickness behavior? So we've talked with people in cancer, for example, and so that when somebody is surviving from cancer, could you monitor them with PRIORI over time and then determine, when something shifts off the baseline, is that a predictor either of mood state variation or recurrence of cancer? Likewise with cardiovascular diseases.
I just want to add something that.
Let's catch June's question first. Then we get.
Yeah.
My question is really wide.
Sure.
You can come.
Go ahead and get.
Okay. Yeah. I just wanted to mention that I'm actually new in this field, and I was working in other fields of speech processing, for example. I worked on speaker verification, speech recognition, or other fields of speech processing. The result, for example, for speech recognition, we have the accuracy of 90-something, 95-something, 96-something. But here you can see our accuracy is 70-something, the best accuracy. So I just want to mention that the field is too young, it's too new, and it's really valuable if we can obtain something in this area. Also, it's
see improvements. It's really what you're saying. Get more data and get better training. You'll improve it.
So I'll make a comment, and then there's a question at the end. So law enforcement keep a record of fingerprint and now also DNA. DNA matching is a very accurate science. It ought to be the envy of other type of matching. I read a fascinating article about facial recognition. So if you build a database of people's pictures, but the real life, collected images, it's hard to match to a database of 1 million suspects. So this article is about, you probably read this, law enforcement in UK are now hiring human who are great at recognizing faces and great at remembering them. The performance for that is way better than support vector machine and everything. So basically the premise of that whole effort is to say fingerprint can be matched to a database. The faces of suspect cannot be matched reliably by machine to a database. I guess my question is, how well do you see the voice can be matched to a database of voices and potentially even different mood states of that person's database?
This is a really interesting question for a variety of reasons, and it goes back to the whole concept of with sensitivity and specificity. And so that I'm a psychiatrist, okay. I am not all that worried about specificity, in the sense of, and so my colleagues in computer science and engineering say, well, we want to be really accurate. they want to be accurate. They really are striving for accuracy. And so he was pointing out, we were 90% and now we're only 70%. This is really an intolerable situation. But for a psychiatrist and a clinician, this is not bad, because really what I'm interested in is this sensitivity, is in being able to predict when somebody's running into an episode. And so I'm interested, in almost in a Markov model as something as the, you could get a hit from day to day, and so you're getting a suggestion the sensitivity is hitting 70%, that there's a likelihood of a depression going on, and that goes on for 4 or 5 days. That is important to me, because that would trigger this early warning light, and then we would need specifically the clinician, the person, as they say in Scotland, the person that would actually interview or interact with the person, with the patient, and determine if there's something to be worried about. And so when the light goes off, goes off for somebody up in the UP, and we're sitting here with a big board, and we call a clinical person up there, you need to check on Joe Blow up in the UP, and the nurse there or the social worker or whomever calls them up, talks to the guy and says, oh, I went on a big drunk this weekend, and but I'm fine now and everything, I feel bad about it, but that's what happened. Or it could be, listen, I just went gambling and I did this and I'm doing that. So you got to get the context of it as well. So that's why I was asking. Yeah, so the whole purpose of this then, Brian, is to be able to triage the individuals for intervention. So if we could so you want to be able to use the health system in the most efficient way that we possibly can. And so if we could monitor, as many individuals technologically and triage those individuals for care, that would be the holy grail of this kind of system. Yeah, you had a question? Okay, yeah.
I think also kind of going off of that, it depends a lot on defining your context, because when you're looking at like a criminal database, trying to match images within that, it might not be at human performance. But for example, Facebook actually has better than human performance on recognizing faces within your own friend groups. They can recognize faces that are completely obscured or blurred out better than individuals can. But that's within a certain context of that platform. So a lot of this is about recognizing the context of where you're working and trying to work within that problem.
So I was going to give an example along the same lines. There was a face recognition competition and there are different universities participated in. And the first place took, actually proud of that, Russian team who actually beat Facebook and Google in face recognition competition. And then they spin it off in a startup. And what did they did? They took a very deep neural network, trained it on there is a Russian social network, vk.com, and they have millions of people. It's like Russian Facebook. So, and then they are open. So they trained their model on all of those images and published an app, mobile app that you can download. You can take a picture of a random person in the street, and it will find it. If that person is on the Russian Facebook, it will find them. And so people started doing that. They would start taking pictures from random people on subway, in the bus, on the street, find them, find their profiles on the Facebook. And that works very well, as you said. It's in the 90s, like the AUC is 90, 92, 95. So it's and then so that company, when they spinned up the startup out of that, they got a contract from Russian law enforcement and police. They're actually now working with them to use that for law enforcement. And the question for you guys, you are very limited in terms of like your data set because it's not very big. That's why you stuck with SVMs, because you have wide pitch vectors and not many instances. Did you consider transfer learning? Maybe look in a bigger speech data sets that already out there, and then there are pre-trained models that you can take and plug your samples in there and see if you can take like those representations.
Yeah.
I'm particularly interested in looking at potentially mid-level features that are trained on external data sets. Like there's some reasonably large emotion data sets that we can use that we can get a measure of how emotional the person is through a conversation, and that is likely tied to their mood patterns as well. So we could extract those sorts of more direct features and then use the more limited data set to figure out how to tie those to mood. So yeah, looking into that.
Because I think I saw Emily and Holak Lee published a paper and they did like deeper model on some emotion recognition or speech assessment, and they had a relatively large data set. I mean, compared to what you guys have. So that would be interesting.
Yeah, for ours, our big problem is that we have a lot of data, but we don't have much labeled data. So we're trying to figure out how to bridge that gap right now.
I have a question for that because would there be a logic then in so if we got people downloading the app and bumping it up into the cloud, so we could so one of the strategies that we're thinking of saying, so why don't you call us, talk to me when you're feeling in that. And so they call in and said, I'm rating my mood as this. And so they give us a label on the rating and said, I'm really feeling shitty. And I want to tell you what a real jerk they were at the University of Michigan. I didn't get in, and I couldn't get an appointment. They got me. So you could get folks
a couple times.
Yeah. So you can is that kind of what you're suggesting or saying that this kind of database could, because we want to be able to generate it for that personalized system for the individual, so that they could call in various different moods, and then the system could learn what they sound like, and so that they would get better at recognizing when the wheels fall off. Is that?
Yeah, if you have large labeled data set that is already out there and other people using it for emotion recognition or something like that, you can pre-train your model on that large data set,
right,
and then fix those learned weights and use it on your smaller and weakly labeled data to get the representations for that.
The problem with the data sets that are out there, and you can correct me if I'm wrong, is that what I've seen a lot of actors, and so that they get people that, say, well, I want you to walk into a room and pretend you're really angry. And so people will get on the, that, and there'll be speech, examples of, really putting contrived emotions on it. So, yeah, put some noise, but so the question I would have is that if we got the patients themselves, and so if we got people that are in our study, it would take longer, we'd be collecting data, but would that be, I think it would be more valid.
Yeah, definitely. Well,
yeah.
There are data sets that they build by showing people sad or videos that they make them sad or happy or angry or something. We actually had a tools and tech presentation on something like that. Someone was collecting the data like that, but it's not as, I guess, not as intense as patient situation. Maybe modality is not the same of that emotion that they invoke in them.
I mean, it at least gives you a starting point from there to be able to
would probably consider trying and see what happens.
Like transfer learning you talked about.
Yeah.
You could start there and then try to transfer the knowledge into the field of more natural mood.
I just want to add something to your point. Actually, it is completely true. We can use other databases and define some mid-level features, because the distance between speech and mood is really large. If we can define some mid-level features here, for example, emotion, or just I'm working on another mid-level features, for example, if we can capture how much this utterance is different from how much this utterance is different from that subject. If you have a model for that subject and you can capture, for example, if you get that to a speaker verification system, what's the score of that speaker verification? Is it really similar to himself or not? That utterance is really similar to himself or not? It can be another mid-level feature, but you're right. We should use another mid-level features to actually handle this low amount of database.
Yeah, that's why more complicated model neural network would be nice, because you can learn joint embedding.
Yeah, for example, for speech verification systems, they use neural networks and they extract these vectors over deep neural networks, and they're actually better than human beings. The systems are more accurate than human beings. But the point is that they have very big databases, and I think neural networks needs a lot of database, but it has not been proved yet.
Mm-hmm.
We cannot say that neural network won't work for small databases. I mean, deep neural network won't. We cannot say that, but usually they use a lot of data to train that.
So what we'd like to see happen, is to get this data in a way or in a manner that could be presented, through the, through MIDAS or in some manner, so the student, wakes up in the morning, comes up with an idea, and go in and then can access at least elements of this data system to run some experiments. The problematic thing with it, of course, is that there's from the audio, I mean, we just have the raw audio. Now we don't do anything with it in terms of its content, but we do have the capacity to reconstruct it, so we can't make it available, even internally because of the IRB issue. So if somebody wants to come and and play in the sandbox, there are more than enough things that can be done. So talk to these guys, about that.
Super. This has been an excellent presentation from all of you, of course, and it's great to have you back and great discussion.
Yeah, thank you. Thank you very much for the opportunity.
Some collaboration.
Absolutely. Thank you for the opportunity.
Super.
Thank you.
Yeah, thank you.